Hello, everybody. I'm Dr. Shravan, consultant pediatric orthopedic surgeon from Ramaya Hospitals in Bangalore. Today, I'm going to talk about the top 10 articles in the management of fractured neck of the femurs. We begin by delving into the history, where we look at the fractures of the neck of femur by A. H.C. Ratliff. He states that the true fracture of the proximal femur are so rare that no one has a great experience of them. This paper was published in 1962. Ratliff, along with 43 other surgeons, contributed about 71 cases to this study. They acknowledge the fact of the severity of injury, which is a very violent trauma to cause the fractured neck of the femur in children. They also acknowledge the fact that there are associated injuries that are present in these fractures and they must be addressed as well. He presented about 7 basic treatment modalities of treatment of these fractures. He classified these fractures based on the location anatomically, and he treated them based on the displacement. The 7 enlisted primary treatment of displaced fractures in 49 patients include manipulation and plaster spica, right up to a primary subtrochanteric osteotomy. He also acknowledged that there is a high incidence of complication irrespective of the treatment in these displaced fractures. He laid out about 10 commandments of the fractured neck of femur. He stressed the fact that these injuries are very rare, the use and the validity of the anatomical classification. He stressed the fact that a very severe violence is required to cause these fractures. Complications in the treatment of these fractures are very frequent, AVN and non-union being among them. A high AVN is seen in the treatment of fractured neck of the femur. This AVN is quite distinct from that seen in Perthes. A primary internal fixation helps to avoid the high risk of complications. Undisplaced fractures have a universally good results. Displaced fractures, the treatment is very unsatisfactory. He enlisted the 7 methods of primary treatment. He also said that salvage procedures in displaced fractures were very common. In the treatment of fractured neck of femur, then we have to delve and go back to the basics. The arterial supply of the proximal end of the humeral femur by Stanley Chung is a visual delight. This work reaffirms Krock's work in the blood supply of the proximal femur. They have taken about 150 specimens which range from 26 weeks period of gestation up to 14 years and 8 months. This paper stresses upon the fact that the intraosseous continuation of metaphyseal vessels supplying the femoral head at birth gradually diminish as the physis forms. The later blood supply is dominated by intracapsular lateral epiphyseal vessels. The vessels of the ligamentum teres have absolutely no importance in the blood supply of the femoral head. In this picture, we can see the femoral artery, the extracapsular ring, the ascending lateral cervical arteries, and the epiphyseal plate. The small and insignificant artery from the ligamentum teres here, and the epiphyseal branch of the posterior ascending cervical artery that is seen here. The arterial supply is very important as an anterior capsulotomy is needed to decompress the fractured neck of the femur. The anterior capsulotomy is safe as long as the intertrochanteric notch and the superior lateral ascending cervical vessels are avoided. He summarized by saying that the 2 collateral arterial rings supply the femoral head and neck. One ring is extracapsular, the other subsynovial and intraarticular. Epiphyseal and metaphyseal branches of the lateral ascending cervical artery originate from a single stem. The subsynovial ascending cervical arteries have metaphyseal and epiphyseal branches. The pattern of extracapsular ring remains unchanged throughout the adulthood. With our Prime Minister encouraging Atmanirbhar, I would like to present a few Indian papers in the next few slides. The overview of the fractured neck of the femur by Dr. Thomas Palokrin is excellent when you want to get a brief idea about the treatment of fractured neck of the femur. He stressed the validity of the Delbet classification, the type 1 being essentially a transphyseal suppression, which is a Salter-Harris type 1 type of a fracture with an incidence of less than 10%. Type 1A is without a femoral head dislocation, and type 1B is with a dislocation. A type 2 fracture is a transcervical, which is the most common, about 40 to 50%. The type 3 being cervicotrochanteric with an incidence of 25 to 35%, and a type 4 intertrochanteric with an incidence of 6 to 15%. He stressed the use of plain radiographs, both the AP and the cross-table lateral view. MRI investigation is necessary in which a non-traumatic cause is suspected. Ultrasound is very essential in infants to find out the type 1 and the type 2 fractures. He concluded by saying that the Delbert classification is reliable and currently the most preferred. Anatomical reduction should be the goal of operative intervention, and displaced fracture should be treated urgently to reduce the risk of AVN. Coming to urgently, the question of timing was brilliantly answered in this paper. Does the timing of treatment affect the complications? This question was answered by Dr. Hitesh Shah, Dr. Vidyasagar Chandankare, and Dr. Kumar Amarendra Singh from Kasturba Medical College. They compared the union time and the frequency of complications in children who presented early, less than 24 hours following injury, with children who presented later, more than 24 hours. In this paper, they review about 32 children with 34 hip fractures, the mean age being 11 years and 7 months. The most common mechanism of injury being road traffic accident and fall from heights. They had 2 type 1 fractures and 10 type 2 fractures that were seen. The 3 variables that they looked at were the union time. They said that all the fractures united. The difference of time of union is statistically significant in both the groups. They had 4 children with AVN, and all 4 had a type 2 Delbert fracture. The neck shaft angle was comparable in both the groups. Coxa vara and premature fusion as complications were seen in 8 cases. They concluded by saying that the frequency of complications is comparable. Delayed union can be expected with late presenting cases. Anatomical reduction and stabilization reduces the time of healing. The fracture of AVN and other complications in fracture neck femur in children is independent of the timing of surgery. The complications may be related to the severity of the injury. The surgeon must consider an anatomical reduction and fixation in all the cases. Coming to a rare fracture, which is the transphyseal fracture. This paper studied about 5 children between 8 to 26 years of age uh, without a dislocation. And let us see what it says. The most common mechanism of injury in this paper, they say, is child abuse. They stressed the fact that they treated all the children without a forceful manipulation. They found out that of all the deformities that were seen with treatment, the coxa vara corrected itself by remodeling. Limb length deformity needed to be addressed in all the cases, either by doing a contralateral epiphysiodesis or a lengthening of the ipsilateral limb. In this picture, we can see a displaced type 1 femoral neck fracture treated with a spica, went on to heal in 6 weeks with callus formation and a varus of 87 degrees. At 1 year follow-up, the fracture has united, but the varus persists. 12 years post follow-up, we can see that the varus has resolved and it has united extremely well. They summarize the paper by saying that these type 1 fractures are rare with a high rate of AVN, 100% if there is presence of dislocation. Less than 2 years, very young children have a very good prognosis in type 1 fractures. Undisplaced fractures are minimally displaced are best treated with a spica. Unstable fractures are treated with smooth pins. Older children need an operative treatment and screws. So what do we do with the displaced fractures in type 2 and 3 Delbets? This question was beautifully answered in this paper by Dr. K.S. Song, displaced fracture of the femoral neck in children. The aim of this study was to determine whether an early anatomical open reduction and internal fixation decreases the incidence of complications. It was compared with close reduction and internal fixation. In this paper, 27 fractures, 11 boys and 16 girls were treated and followed up over 18 years. All the open reductions were done in a period of time from 1989 to 2002. There was no close reduction attempted during this time in the belief that a close reduction causes a vessel damage. The close reductions were done from a period of 2002 to 5 when they believed that open reduction in almost all the cases was an overkill. Open reduction was done by a single surgeon. A standard Watson-Jones approach was taken. There were 15 Delbert type 2 and 12 Delbert type 3, 8 open reductions in type 2 and 7 open reductions in type 3. They divided the outcome of their fixation into 3 groups. The first one being an anatomical reduction, which was seen in 14 out of 15 open reductions. Group 2 with acceptable reduction, less than 2 millimeters of displacement and 20 degree of varus in 8 out of 12 closed reductions. Unacceptable with greater than 2 millimeters of displacement and greater than 20 degree of varus seen in 1 out of 12 closed reductions. He stressed upon the fact that early capsulotomy and open reduction reduce the complications of fractured neck of the femur. The type of the treatment, he says, has a greater influence than the fracture in the neck of femur. He enumerated the hazards of a close reduction. He says, what constitutes acceptability is arbitrary. The number of times we attempt close reduction has to be defined. The unreliability of fluoroscopy in identifying reduction, and the very fact that we can jeopardize vasculature with close reduction was emphasized. Coming to the urgency of fixation, this was very well elucidated in fracture neck of the femur in pediatric fractures, a 30-year experience. He talked about the complications resulting from the time of injury to reduction, outcome based on the reduction, the mechanism of injury in, as seen in most other papers, being a violent trauma. 15 patients were treated with less than 24 hours from the time of injury in this paper, and AVN was conspicuously absent in the group with anatomical reduction. They demonstrated an increased AVN risk with a delayed fixation. They did not associate AVN with performing a capsular decompression. This study was retrospective in its method. Coming to the Indian scenario, where the treatment analysis of pediatric neck fractures was done in a prospective study. This study was done in three centers in Odisha, India. 28 children were observed. They divided the fracture neck of children into 4 zones, with the zone 1, they say, being highly unstable, and zone 4 being the most stable. This is a screenshot of their planning protocol, where they have divided the fracture zones and the fracture neck of the femur into 4 zones based on anatomical locations. 28 children were studied in this paper, 16 boys and 12 girls. 16 children, they presented between 24 to 48 hours from the time of injury. In this paper, they stressed the use of a postoperative spica in children less than 8 years of age. They allowed partial weight bearing only after 6 to 8 weeks of fixation. Till then, the child was absolutely non-weight bearing, and full weight bearing was allowed only after union, which is about 14 to 16 weeks after the time of fixation. They observed AVN in 4 cases, and they attributed it to the presence of and the decreased rate of AVN, they attributed it to the presence of early presentation, decompression, and anatomical reduction. They observed non-union in their cases, which they attributed to the screw not crossing the physis. They maintain that the penetration of the physis may be necessary for stability in type 2 fractures, maybe a little less in type 3 fractures. If the physis is not crossed in type 1 or type 2 fractures, the child must be protected and the fixation must be protected with a spica. Early surgical intervention, they say, hastens recovery. Implant selection forms an integral part of anatomical fixation. Smooth pins in zones 1 and 2, cancellous zone screw fixation in zone 2. Initial trauma and disruption of the head vascularity is the most important cause of AVN. Decompression of the hip joint by capsulotomy, they say, helps check the tamponade and should be performed in all the cases of fracture neck of femur. Now, let us look at why stable internal fixation is important in this paper of 10 years of experience in PGI Chandigarh. A total of 36 hips with a minimum of 1 year follow-up was studied in this paper. They say that a type 4 Delbet displaced fractures are best treated with a pediatric THS in a derotation screw. The risk of AVN, they enumerated, depends on several factors, including age, degree of displacement, the type of fracture, time to surgery, and the method of fixation. The most important factor, most likely, the severity of vascular compromise sustained at the time of trauma. Internal fixation should be performed whenever possible. These fractures are inherently unstable in children. The fracture neck of the femur consists of smooth, hard, dense bone, which does not have the typical adult trabecular pattern. The fracture lines are often uniplanar, which not like spiral and triplanar in adults, less jagged, very little interlocking patterns, which make them very unstable. The loss of reduction occurs very commonly in a traditional hip spica. The musculature tends to pull the shaft in the cranial direction, and as the spica is open at the top, it can never provide stability in this direction. An inherently unstable fracture is very likely to displace in a spica, and internal fixation goes a long way in preventing complications. Coming to the final nail in the treatment of acute pediatric neck fractures, AVN. This paper analyzed the risk of AVN in 25 cases of the Cincinnati hospital and a meta-analysis of 360 cases. They say that there is no curative treatment available for AVN once it is identified. The best treatment, therefore, is aimed at preventing the occurrence of AVN. They did a logistic regression analysis and said that fracture type and age were identified as the only two statistically significant variables. Powerful evidence that older children with type 1 and type 2 are at the highest risk of avian development. Prediction of avian is controversial as there are multiple mechanisms. Insults to the vascular supply may occur during the initial trauma, during the process of reduction, and during the process of fixation. Younger children are at a less risk because of the increased ability to revascularize and remodel, contradictory in the adolescent where there is decreased ability to remodel and the vascular supply being very tenuous. The current review of literature shows a general consensus that a displacement is critical, if not the most important predictor of AVN. Thank you.